Understanding Fracture Neck of Femur. The video is created by Dr. Abhinav Gupta and team. In this comprehensive video, we have covered everything about the topic from initiation to the end. A fracture of the neck of the femur, or hip fracture, occurs when the top part of the thigh bone, femur, is broken near the hip joint. Categorization includes intracapsular and extracapsular. 1. Intracapsular, occurs within the capsule, which is the connective tissue surrounding the joint. Subtypes include subcapital, below the head of femur, and transcervical, across the neck of femur. 2. Extracapsular fracture, occurs outside the joint capsule. Better prognosis compared to others. It includes fractures of the trochanteric region and the subtrochanteric region, below the trochanter. The etiology of a fractured neck of the femur can be diverse, but the most common factor is trauma, often related to falls. Several risk factors contributing to it are as follows. 1. Age, due to factors like decreased bone density and an increased risk of falls. 2. Osteoporosis, weakened bones, commonly associated with aging. 3. Gender, postmenopausal women due to decreased estrogen levels affecting bone density. 4. Medical conditions, like osteoporosis, osteomalacia, and other bone disorders increase the risk. 5. Medications, prolonged use of corticosteroids, can weaken bones and contribute. 6. Falls, accidental falls, particularly in older individuals, are a leading cause of hip fractures. Seven. Genetic factors, family history and genetics can play a role in bone health and fracture risk. 8. Nutritional factors, inadequate intake of calcium and vitamin D can impact bone strength. Mechanism of injury. 1. Falls. The majority of hip fractures occur when an individual falls, especially in older adults. The impact on the hip joint during the fall can lead to a fracture. 2. Direct trauma, high-impact accidents, such as car collisions or sports injuries. 3. Twisting injuries, sudden, forceful twisting especially where the foot is planted and the body turns. 4. Pathological fractures, weakened bones due to underlying conditions like osteoporosis or tumors can lead to fractures even with minimal trauma or stress on the hip. Clinical features. 1. Severe pain in the hip or groin area. 2. Swelling and bruising around the hip or thigh. 3. Inability to bear weight on the affected leg. 4. Shortening and external rotation. 5. Restricted roam. 6. Tenderness. 7. Possible neurovascular symptoms, such as numbness or tingling, indicating nerve or blood vessel involvement. Diagnosis. X-rays of the hip, AP and lateral views helps to make diagnosis. Aims of treatment. 1. Anatomic reduction, to restore the normal anatomy of the hip joint. 2. Stable fixation, to prevent further displacement of the fracture and promote optimal healing. 3. Pain management, through a combination of surgical intervention, medications, and physiotherapy. 4. Facilitating early mobilization and weight bearing as tolerated to prevent complications. 5. Prevention of complications, such as infection, DVT, and pressure sores through proper surgical techniques and rehabilitation. 6. Restoration of function, including roam, strength, and mobility. 7. Prevention of recurrence, addressing factors such as osteoporosis. 8. Rehabilitation. 9. Patient education about the postoperative instructions and lifestyle modifications. 10. Improve quality of life. Treatment option. 1. Surgery, to stabilize the fracture and promote proper healing. May involve procedures like internal fixation, using screws, plates, or rods to hold the bone in place. 2. Hip replacement, in cases where the fracture is severe or there are underlying joint issues. This involves replacing the damaged joint with an artificial prosthesis. 3. Pinning. For certain types of fractures, especially in younger individuals, surgical pinning may be an option. This involves inserting metal pins to hold the bone fragments together. Physiotherapy assessment. 1. Pain assessment. Evaluate the intensity and location of pain. 2. Range of motion, ROM. Assess the limitations and any discomfort during passive and active movements. 3. Muscle strength. Evaluate hip muscles, especially hip flexors, extensors, abductors, and adductors. 4. Weight bearing. Determine the patient's ability to bear weight on the affected leg. 5. Evaluate balance and coordination to identify any deficits that may impact the patient's ability to stand and walk safely. 6. Functional mobility. Assess ADL and gait pattern. 7. Joint stability. Check the presence of any abnormal movements or instability. 8. Assessment of assistive devices, if required, such as crutches, walkers, or canes. 9. Neurological examination. Evaluate sensory and motor function, to identify any signs of nerve injury. 10. Consider the patient's psychological and social factors. While specific physiotherapy management protocols may vary based on individual cases, here is a generalized day-wise outline for the early stages of rehabilitation. Day 1 to 3, immediate postoperative period. Pain management. Use modalities like ice, elevation, and pain medications as needed. Bed mobility exercises. Initiate gentle ankle pumps, knee bends, and isometric exercises to maintain circulation and prevent stiffness. Breathing exercises. Encourage deep breathing exercises to prevent respiratory complications. Gentle range of motion, ROM. Perform passive hip and knee range of motion exercises within the comfort limits. Isometric muscle contractions. Engage in isometric exercises for muscles around the hip and knee to maintain strength. Assisted bed transfers. Begin with minimal assistance for bed to chair transfers. Day 4 to 7, early mobilization phase. Ambulation practice. Start partial weight bearing exercises with the assistance of a walker or crutches. Active ROM exercises. Initiate active range of motion exercises for the hip and knee, incorporating flexion, extension, abduction, and adduction. Strength training. Progress to resistive exercises for hip and knee muscles using resistance bands or light weights. Balance and coordination exercises. Include exercises to improve balance and coordination. Assisted stair climbing. Begin practicing stair climbing with assistance. Gait training. Focus on refining the walking pattern and stride length. Week 2 to 4, intermediate rehabilitation. Full weight bearing. Gradually progress to full weight bearing activities. Functional activities. Emphasize activities of daily living, ADLs, such as sit to stand, squatting, and stair negotiation. Endurance training. Introduce cardiovascular exercises like stationary cycling to improve endurance. Joint mobilization techniques. Implement joint mobilization techniques to improve joint mobility. Muscle strengthening. Increase resistance for strengthening exercises, focusing on functional movements. Patient education. Provide guidance on home exercise programs, self-care, and fall prevention. Week 5 and beyond, advanced rehabilitation. Progressive resistance exercises, advanced resistance and intensity in strengthening exercises. Advanced balance exercises include challenging balance exercises to improve stability. Functional progression. Work on more complex functional tasks and activities. Return to normal activities. Gradually reintegrate the patient into normal daily and recreational activities. Ongoing home exercise program. Emphasize the importance of continuing exercises at home to maintain gains. Complications. 1. Non-union. In some cases, the fractured bones may fail to heal properly, leading to a condition known as non-union. 2. Malunion. Improper healing of the fracture that results in misalignment or deformity is referred to as malunion. 3. Avascular necrosis. Disruption of the blood supply to the femoral head causing the bone tissue to die. 4. Osteoarthritis. Usually develops over time on the side of the affected hip. 5. Infection. Surgical procedures carry a risk of infection, and postoperative infections can occur around the site of the fracture. 6. Deep vein thrombosis, DVT, and pulmonary embolism, PE. Immobility and surgery increase the risk of blood clots, DVT, which can travel to the lungs, PE, and pose serious health risks. 7. Complications from anesthesia. 8. Pressure sores. Immobilization and extended periods of bed rest can increase the risk of pressure sores. 9. Functional impairment. Despite treatment, some individuals may experience lasting functional impairment and limitations in mobility. 10. Psychological impact. The trauma and challenges associated with the hip fracture can have psychological effects, including anxiety and depression. Vote of thanks. Thank you for watching our video. We hope this information has been valuable to you. If you have any further questions or concerns, please consult our team for